So every 3 minutes in America, a limb is lost due to diabetes, and most of these, surprisingly, are actually preventable. A big factor leading to amputation is a lack of blood flow. It's important for patients with diabetes to get regular checkups of the blood flow in their leg and foot arteries. If it's not flowing, it's important to have a vascular specialist restore blood flow by clearing blockages in typically the lower limbs and feet, especially in those patients who have wounds that develop and won't heal due to the lack of blood flow. And speaking of those wounds, another leading factor in amputation is those non-healing diabetic ulcers. Here to talk about research and innovation in foot care for patients with diabetes and peripheral artery disease are Dr. Stacia Jones, podiatrist with the VA out of Virginia, also the father of diabetic foot care, Dr. Lawrence Harkless, and Dr. Gary Rothenberg, podiatrist and director of medical affairs for diabetic foot technology company Podiatrists. Thank you to you all for being here. If you want to jump on and say hello and unmute so that we can see who you are. Dr. Jones, do you want to say hello?
Yes, hi everybody. I'm honored to be here. I'm a fan of all the work that Kim has done for everyone. She's so informative. I recently transitioned from military to the VA. So I'm seeing a lot of the patients that we've been talking about all morning. So it's kind of like a nice fresh. I was glad to join in a little earlier to talk about what's the latest and greatest with vascular surgery. I haven't had a chance to physically meet the vascular surgeons in my hospital yet, but I do refer to patients all the time to them. So I'm here to, give you guys as much information as I have to share and hope we can all learn together.
And I think it's so important. We're going to just jump right in here. That toe and flow model, the podiatrist and the vascular specialist working together. Dr. Rothenberg, very important, isn't it?
I certainly think so. It's definitely, it makes a whole lot of sense. Those are the two main specialists, I think, that are really at the forefront and on the front lines of helping folks to keep toes on feet and feet on legs and legs on lives to keep people healthy, productive members of society. I think that's what we want to do. And there's certainly great centers of excellence doing that toe and flow model across the country.
And Dr. Harkless, you are the father of diabetic foot care. I'm curious from your standpoint, what drove you to become so passionate about this particular area of study? And then how has it evolved since your passion really set in?
Well, it all started in San Antonio, Texas at UT Health Science Center, the county hospital in San Antonio, where I started as an intern in '75, but I came back later, 2 years later, on the faculty. And our patients were probably about 83% Mexican-American, lots of diabetes. And I was just learning. I was seeing a lot of disease and the toughest of patients because of the vulnerable population, access to care, all the things that we deal with in those particular tough groups of patients to treat. And being at a major university, I had conference every week where we would present cases, and we were always raising questions clinically that we needed to answer. And so that stimulated, research, the University of Texas Wound and Wrist Systems, all of those particular things, they emanated from trying to solve issues that the patients had in that regard. And I want to mention one thing. You mentioned toe and flow, but I have a lecture I give called Toe, Flow, and Metabolic No. And so I believe that if we could explain at the cellular level what's going on with the patient in a simple anecdote or riddle, I've yet to have a patient who will not change their behavior, because it's the behavioral aspects of things that impact all of this of what we do. And that's just the health disparities, the health equity, all of those things in the vulnerable population, which tend to be minority populations, which we quite know quite well.
Yeah, that's an actual.
I'll stop and we can
really
start answering questions.
No, I think that's actually really
Yes.
important. And I think that people would want to, what questions can they ask their doctor to get to that metabolic level? Because I agree with you that if you get to that level and you can show a patient what's really happening and have it be measurable, I think that that's critical.
Well, let me say this, and I don't want to steal the thunder. Dr. Rothenberg can probably say the same things I'm saying, but there are 3 cells in the body that do not utilize glucose well inside the cell. And that's the mesangial cell, endoglomerulus in the kidney, the capillary endothelial cell in the retina, and the Schwann cell and the nerve. And so that's why you go blind. That's why you end up on dialysis. That's why you end up with an amputation. So you got to start at that level in terms of what inflammation does at the cellular level when your blood glucose stays over a certain level. And if you can get that patient to understand that, they'll lose weight and they'll change their behavior and they'll understand that because they will probably have a family member. Everybody knows somebody somewhere, a relative, someone at church, just a socialization of life. We know people with diabetes. I'll stop there and we can talk more.
Dr. Rothenberg, do you want to jump in?
Sure. I mean, I am actually a disciple of Dr. Harkless. He was my residency director 25 years ago in San Antonio, and he was teaching me about social determinants of health when that phrase was not around 25 years ago. And those things are really important to understand. The biology, the psychology, the burden of diabetes, the emotional burden of diabetes, the physical burden of diabetes, as well as certainly the financial burden that it has. So I think all of those factors are really important to consider when managing patients with diabetes and avoiding problems like foot wounds and Charcot-arthropathy or unusual conditions that affect people with neuropathy in the feet, for sure.
Dr. Jones?
Yes, currently where I work at the VA has, we're giving out mats to patients that are high risk. So whenever we see a patient, we do a full diabetic risk assessment evaluation on them. And because I'm new to the VA, I treat every patient like a new patient. And so if they have calluses, obviously calluses lead to ulcers, which lead to amputations. So we are distributing these mats that we mail it to the patients, which I think Dr. Rothenberg is probably going to have some information to diverge on that later on. But like I said, this is a new study that we're required as podiatrists to do and mail to all of our diabetic patients that we see, and we put them in different high-risk categories. And so based on that, that also determines how often they come back to us and we, get to monitor them throughout the year.
Wow, that was such a great segue, Dr. Rothenberg.
Sure.
So talk about podiatrics? What are those mats?
Sure. So what Dr. Jones is referring to is actually temperature monitoring. Even Dr. Harkless just mentioned, inflammation precedes complications. It's no different actually why fever is part of when you get a viral infection or when you get a bacterial infection. Temperature goes up. So Dr. Paul Brand, who Dr. Harkless knew very well, 50 plus years ago in the 1970s, was documenting and looking at the fact that temperature precedes and inflammation precedes complications in feet. So what we're looking for with the smart mat is actually a fever in the foot. It's really temperature monitoring, which can predict ahead of time that there may be a wound or an infection or some sort of complication that is brewing in the foot. So it's a simple mat. It's an innovation of some technology with which Drs. Lavery and Armstrong and Dr. Harkless, again, in San Antonio. And we were studying these patients in the late 1990s, early 2000s, and comparing feet. So now the innovation that Dr. Jones mentioned, the smart mat, patients stand on this mat it takes 20 seconds to get a scan. And we're looking for asymmetry. So does the right big toe and the left big toe, are they comparable in terms of temperature? If there's an asymmetry or a difference, that could be a sign that something is going on or that something is brewing. So it's really not only about the technology which has been innovated, but we also monitor that. It's called remote temperature monitoring. So we have Podiatrics has a set of nurses who I call them the angels in the cloud, because all of your scans, the patient scans, are monitored remotely. And then if there is a complication or potential asymmetry noted, our nurses get in touch with the patients and warn them ahead of time. Hey, maybe this is not the week to do Christmas shopping, or what's going on with your feet? Can you take a good look at them? And then we also escalate to the provider, like Dr. Jones. If she's prescribing those mats, we may come back to her and say, we've called your patient several times. They're noting that there's some bleeding on the underneath the big toe joint. And then it's up to the providers to see. But temperature monitoring is preventative care. It is scientifically sound. it is a really important and useful tool. And the research shows that we can detect 97% of foot complications at a 5-week lead time. So imagine having that information ahead of time and being able to intervene and change destiny and not allow wounds to occur, which the wounds can lead to infections, and infections lead to amputations.
Yeah, I would imagine, Dr. Harkless, I mean, the biggest problem that we have, I mean, it's great, you restore the blood flow and it does expedite the healing process, but once you have those wounds, even with blood flow, it's a bear to heal those wounds, those diabetic ulcers. It's a lot of time and energy and resources.
Well, I'm still biased. I don't know if I have all the research to answer. Maybe Gary and Dr. Jones can allude to that. In about 5 or 6 cross-sectional studies, the average healing time for a neuropathic ulcer is 4 to 6 weeks. That's the gold standard. That hasn't changed through a total contact cast. And what happens is that the wound is open and they're not aware of it. You have bacteria on our skin, it socializes, and it we prevent develop an infection. And so that's the most common reason for an admission to the hospital. And if you have a good team, the probably length of stay is probably about a day and a half to drain staph or strep or whatever. But if you have a really bad infection, they're probably in there longer. Now, if you add PAD to that, then that increases that stay because you have to consult vascular surgery, et cetera. And so this is not, what makes it difficult is that you tend to have overlapping problems. You can have just a primary infection, well, you have neuropathy, infection, that, and PAD. And if you use a Venn diagram of how those things are interacting, it takes some experience and seeing a few patients to understand all of that, to know what to do and when to do that in the appropriate times. And I'm still biased. I really think that if you probably don't train in a county hospital, most medical schools in America, there are 165, will have a VA and a county hospital as the primary teaching hospitals. Now, they may have a couple of private hospitals, other places where they rotate, but that's where the patients come with all the disease. And if you're there training and learning in that environment, that's why Dr. Rothenberg's training, or why I became so good. The patients, I have a lot of scars on me for what the patients taught me that I had to learn. And I always say a mistake is not a mistake until you do it twice. Are we learning and are we actually teaching the patients? And so you can't separate the history from that and getting all the information correctly and then assessing that and following the patient up, very, 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 very closely. But I do think that the innovations are good if you can monitor the patient. But the key is getting them to buy into understanding the process and what they have to do, to prevent those things. And I think everybody wants to do that. But today, there was an article recently published by Don Berwick on the existential threat of greed in medicine. And so I love that article because everything he wrote in there was what I've been thinking about as the whole process. I'm not saying we don't need to make money because we need to do that. But a lot of times it's basic, simple things that are needed. So I think that the mat that he's talking about, the way to monitor the temperature, that you can send it back to for remote monitoring to remind patients, et cetera. And then diabetes increases as we age. And I'm 72 and I'm getting a little bit forgetful. And so I can imagine when I get 80 something and I have the gene for diabetes because all my family members has had it. So the likelihood for me getting that is important. So that's why I'll take a team of people doing that with the monitoring, with the nurses, with the PAD, the toe and flow that you were talking about, et cetera. But the key is in 165 MD medical schools, you may or may not have no podiatrists there. And what I learned is that the foot tend to fall between specialties in medicine. And all the MDs are running wound centers. They don't know what the podiatrists know. And so that needs to be corrected as well. If I had to correct one thing, I'd put a full podiatrist staff with residents in every major medical school in America, and it would change the whole landscape of that. But money gets in the way and the politics gets in the way of all kinds of things that prevent that from happening. But that's a major piece.
I had no idea that stat. I didn't realize that I know we're at a shortage of endocrinologists, but I didn't realize we were in a shortage of podiatrists as well in many areas of the country.
Well, there's not a shortage. I think they're there, but there are turf issues in medicine. And some of the turf issues prevent podiatrists from being there, integrating in the way. They don't know what they don't know. And that's all I'll say. I'll leave it at that.
Yep, no, I'm right there. I'm right there with you on that. I want to go back to Dr. Jones and Dr. Rothenberg on the mat as well. And I'm wondering, in terms of the availability and democratizing access, especially to some other vulnerable communities, will this mat be economical to distribute to the masses?
Well, we have definitely seen the biggest users currently of the mat are veterans. I think the point also that I wanted to elaborate on what you just asked Dr. Harkless too is, and he taught me again 25 years ago, think about risk stratification. Think about where these patients are on the risk spectrum of the disease process. So the biggest predictor of a future wound is having had a wound. So we also have to understand and risk stratify these patients. And if you have diabetes and it is well managed, eventually living long enough with the disease process, you may be vulnerable for developing complications. But well-controlled diabetes is the leading cause of nothing. It is poorly controlled diabetes that leads to these complications as well. So I think that's an important process, but you're specifically asking about the mat, and we understand that we need to see patients routinely. In addition to all of that, there's the significant role of shoes and inserts and preventative care that podiatrists generally do, and education. So once we risk stratify patients, and I think that's probably our biggest job as podiatrists in the diabetes patient population, and we understand that they're high risk for developing problems because they have neuropathy, because they have already had that pivotal event of a wound or an amputation, then we need to make the significant investment because, again, the strongest predictor of future wound is previous wound. So I think getting back to your specific question, Kim, we know that if we invest in this high-risk patient population by doing good preventative care, then that will pay off financially on the back end. It's not only the right thing to do to avoid further complications from a quality of life standpoint, but financially, preventive care is inextricably better than essentially what we're doing is prevention is healthcare, right? Treatment, and while we do have wonderful wound care products and devices, treatment is sick care, and we're trying to get to prevention, not treatment.
And so when we're talking about treatment, I'm going to open it up to all of you, and maybe we'll start with Dr. Jones. What are some of the advances in wound care? So once we do get a wound, one of the toughest things that we have with our patients is trying to guide them to the right, podiatrist who has multiple, options. Do they have fish skin? Are they using newer tools and techniques for debridement? What are some of these newer tools and techniques that are expediting the healing process for a lot of these diabetic ulcers?
Well, I used to work at a wound care center when I was in private practice. So when I was in private practice and working at a wound care center, I was exposed to the latest and greatest because the reps will come to the wound care center. They want you to use their products to help increase wound healing. Now that I am transitioning from where I was before, I'm at the VA hospital. I am the person, we don't have a wound care center at our VA hospital. So I just met with a rep the other day. It's a device that they will mail it to your house and it's like a boot and it's an at-home extremity chamber. I'm not sure if Dr. Rothenberg and Dr. Harkless is familiar with this equipment, but you basically put it on for like 90 minutes a day. Instead of actually going into a hyperbaric chamber or a wound care center, you do it at home. So I just met with the rep actually yesterday at work. And so there's a lot of new technologies that are out there besides what I was used to being exposed to when I worked at the wound care center. But I think in order to get wounds to heal, if you don't have the blood sugars are not controlled, if you don't have blood flow, oxygen, air, and all those things it's a comprehensive that's going to get that wound to heal. All these products, we can put any product we want, but if we're not getting blood flow down there, nothing's going to help.
Dr. Rothenberg?
Sure, I agree. I mean, I think there are innovations in wound care treatments which are exciting. You mentioned fish that comes out of Iceland. There are skin substitutes, topical oxygen treatments that Dr. Jones mentioned. The research is coming out and it is better, specifically with that technology. I remember, again, when I was training, there wasn't such great literature on hyperbaric oxygen. Again, it's controversial. We can debate why that is. We tend to reserve some of those treatments for the sickest of the sick patients. And so when you don't get great outcomes, in a very comorbid patient population, then the product gets a big red X against it. So I do think that there are excellent products out there, but again, the tenets that Dr. Jones is mentioning, if you have a wound on the bottom of your foot, you have to relieve the pressure. If you don't have blood flowing to the area, you have to get circulation there. If your blood sugars are not well managed, you have to get those under control to help support wound healing, because the nature heals the body, right? All of those products potentially speed up the process, but I think it's getting those strong tenets of good medicine before you even go to some of those fancy products.
Dr. Harkless,
Yeah.
what are you most excited about?
Oh, I don't know. I've been doing more academics than I have been treating patients, I guess, over the last, say, 5 years or so. But I consider simple VIP very important person, but that's vascular infection and pressure. If all those are equal, anyone should heal. And if it's not, then you need to assess which one and why, and consult or do what you need to do. I think that when we look at the big picture, it's a population health, workforce, and interprofessional education. It takes a round table, not the doctor up in the vertical part telling everybody what to do. It has to be a round table where everybody's participating, at the highest level. That's where you'll get the best care. And most centers have all of that. And some patients need to be sent to the center to get the tune-up. Now, by Dr. Jones being in the VA, she has everybody there. The only thing she has to do is get excited about educating them all there at the VA about what they don't know, to get them to participate with her so that she can provide all that care and to educate them about what she's doing with her mats. That's really, I think, is the big picture. And finally, we mentioned the social determinants of health. I think that's still the biggest impact on that. And so when Dr. Rothenberg was articulating about the risk system, we need to add the social determinants of health into the risk system and then reevaluate that system to make sure that that's being utilized comprehensively on a global basis, USA, but also on a global basis to include that. Now, Dr. Robel, who was at Michigan with Dr. Rothenberg, gave a lecture, and he basically summarized that so eloquently about what's necessary in the risk stratification that's been out for 20, 25 years to make it better. So we need to do that and validate it in good research in several major centers. And then that way we'll be on our way with the blueprint for doing that. But the challenge is, how do you translate research into practice? And that's the biggest barrier. It's hard to change behavior in doctors. We get indoctrinated in training, and then we tend to stay there if we don't go to conferences and rounds. And so to me, that's where the academic center comes in. If you go to any medical school this week, every department will have case conference, grand rounds, combination of both every week. And you have UME students, GME, residents and fellows, and CME, which would be faculty, private practitioners, and retirees. And everybody called that lifelong learning. But everybody ain't there to get the dose of it that they need on a consistent basis.
We have a fantastic question coming in here. So we've talked a lot about the criteria you use in choosing the right podiatrist and the fact that not all are created equal. And that goes to show as well when it comes to podiatry, because you have some that specialize in sports medicine and other ones that are more orthopedic, and then you have the diabetic foot specialists, right? So how do you as a patient, because when you get referred, a lot of times the podiatrist will just do what they can, not knowing what they don't know, simply because you were referred to the podiatrist. So what are the criteria that patients can use in terms of choosing the right podiatrist for diabetic foot care or PAD foot care? What are the questions they ask, and what are the criteria they should use? And I'd love each one of you to take that question.
I guess I'll go first. I'm also board certified in wound care, so that would probably be an advantage to a patient who's a diabetic and has issues already with diabetes, to kind of focus in. And when I was in private practice, it was on their website and it had my credentials as far as what I focused on. So a lot of podiatrists in private practice, it'll be on their website and it will say whether, they have exposure to diabetic wound care. I was also a part of the American Diabetes Association, and I had that on there as well. So you want to look at someone that actually takes an extra step in focusing on diabetes, if that is your focus. Obviously, if your focus is sports medicine, you want to go to a doctor, whether it's a podiatrist, ortho, that focus on sports medicine. But initially, and I also went to the wound care center. So if you came to my practice and you had a wound, my goal, like Dr. Harkless said, I actually tried to heal every wound within 4 weeks. If I cannot heal it in 4 weeks, that's when I transfer those patients to a wound care center. And then I was their wound care doctor because I actually worked at that center that I refer patients to. So you want somebody that you're actually learning from. Sometimes I get patients, they're like, oh, I've been going to a podiatrist. They've never done that. I saw a new patient the other day that just switched from private practice to the VA. And the wife was there. She said, oh, that doctor never did these things, never taught us these things. So you want to make sure you're with somebody that's teaching you, you're learning new things when, they can say to me at the end of the appointment, oh, I've never learned this before. I really appreciate you at the end of the visit. And you also want to make sure you're with somebody. You can ask as many questions, but you want somebody that's going to be a thorough. You don't want anyone that's going to rush you your first appointment. You want to make sure someone's teaching you. Like as I do certain things with patients, I actually talk to them. I tell them, what's the purpose? Why am I doing this? I talk to them about their diabetes. I have a conversation with them about their health while I'm examining their feet and tell them the purpose of certain things that I'm doing, at their visit. So patients, really appreciate that.
Dr. Rothenberg?
Sure. I think, Dr. Jones covered a lot of it. The internet's a great source. I do think that the following primary care physicians who follow the American Diabetes Association guidelines and recommendations, that's just paramount. So the American Diabetes Association would say every patient with diabetes needs a comprehensive annual foot visit. So, hopefully your primary care doc, while they're very overwhelmed managing everything, they're getting you as a patient to the foot care specialist, at least on an annual basis, to do that screening. And hopefully the primary care docs know who in the community is doing the good diabetes work as related to limb salvage and prevention of complications. So I think it goes back there. I do also really encourage patients to advocate for themselves. When you're in the primary care doctor's office, don't wait for them to ask you to take your shoes and socks off. While you're waiting on them, take your shoes and socks off. You need them to also screen at every visit as well. So I think it does boil down to patients knowing, what does the American Diabetes Association recommend? What does good comprehensive screening and preventative care look like?
I think that is so. The American Diabetes Association has really done a great job. Their new PAD campaign has been incredible. I love the direction they're going. I love the people they're involving with it. And they're really taking a very aggressive approach. And so their website is a fantastic resource. And what's great is they also direct them to our site to help find a doctor. To our
I think that's
hotline,
great. Nobody has to reinvent the wheel, right?
Yeah.
Some really smart people are doing consensus work. And as you mentioned, the American Diabetes Association and partnering with Amputation Prevention Alliance and other great organizations, and just follow those guidelines. Yeah.
Yeah. And I believe we actually just really quickly, I know we're running a little late, but we have Tony, who I think just joined us. She is the caregiver for a patient who has diabetic foot care. Tony, do you want to jump in? I know that you prior to this session had some insight or to share or a question for, Dr. Harkless, Dr. Rothenberg, and Dr. Jones.
Hi, doctors. Thank you very much for being with us today. Some of the horror stories that you guys talk about and I've heard throughout the morning, that's Derek and I. We've had kind of a horror story, and we've been through everything, matrices and maggots and fish skin. I think that it's important that, when the doctors are putting like the wound bandages on, they have to keep in mind that they're dealing with PAD patients, because some of the things that have happened to us is, Derek will go to the wound clinic, come back, and I'll have to go change his wound pad maybe a day or two later. And the pads are on so tight, you can barely get the scissors through there, and really just making sure that keeping the wound pads clean and everything. I've noticed that Derek had a TMA, which is a amputation of all his toes, and it's been very, very difficult to heal that wound. And that's with good blood flow and keeping the sugars under control. And I agree with Dr. Haskell, who
Harkless. Mhm.
Harkus, who says there is definitely a socioeconomic problem with diabetes and wounds, because I know I lost my job, we lost good insurance, and all of a sudden it's like everything was getting worse. And when you're constantly, working and everything, Derek had no idea what was happening until we were full blown into a huge problem, and all they were doing was amputating, amputating, and amputating. And so being a big advocate for yourself, I think, is pretty much critical. So I agree. I'm so happy that you guys are here for us and are answering so many of the questions that we need, and helping us understand the disease.
Yeah, fantastic. Hi, Derek.
Hi, Kim.
Thank you so much for you guys, jumping in. Dr. Harkless, I want to finish off with you. Any final takeaways, any thoughts on what's been said before we move on to our next session?
Oh, no, I didn't really have to say. I thought it was a great session. And I really thank y'all for inviting me. I think Dr. Rothenberg had asked me to participate, but I really think it's all about having the best trained podiatrists to be involved in that process. And if they're part of that, I think you'll get overall better care. And the social determinants of health is really so important. I can't begin to tell you the amount of times where I didn't recognize something and that came into the picture. And I felt so bad about it that I didn't recognize it with that. And I need to thank you all, because my wife is going to kill me. I got to drive somewhere and we're running late, so she's going to kill me. But I appreciate you all taking the time. And it was a great session. Dr. Jones, good to see you. I have to give you a call sometime and we catch up.
Yes,
Thank you.
pleasure to see you, Dr.
And I'm going to leave.
Thank you so much, Dr. Harkless. We just appreciate you so much being here. Final thoughts, Dr. Jones. Any final takeaways? I'm curious, and I know this is just probably a loaded question. We hear a lot of patients talking about just the overuse of the betadine. What are the indications as you close out for using betadine? Because there are some that literally use it for everything, and that is their answer to everything wound care.
So betadine is hypotoxic to the cells. So therefore, I actually do not use betadine. Initially, I know I look very young, but when I first went into podiatry school, we used betadine. We round on the patients in the hospital. I did my residency at a community hospital in New York City, like Dr. Harkless talked about. So I had the most non-compliant patients in New York City has to offer in the demographics where I did my residency. We use Dakin solutions. I know Dr. Rothenberg can relate to Dakins, and we use betadine. Now, I do not use betadine on any of my patients. I would use it on patient with that a doctor is allowing to auto amputate a dry gangrene. As right now, that is the only time I use betadine. I do not use iodine on anybody, or hydrogen peroxide. I know patients like to use that one too.
Oh, wow. So what should a patient ask their doctor? Should they get a second opinion at that point? What should they do?
Well, I use saline solution. Saline is very much readily available anywhere. Obviously at my clinic, I have a lot of wound care, wound washes and things like that are going to be too expensive, but you can go to CVS, Walgreens, Walmart, you can get something simple as saline solution. And that's what you can use to rinse off the wounds and anything like that you have in your foot. But I do not recommend hydrogen peroxide or iodine.
Dr. Rothenberg, final thoughts, and you can key off of Dr. Jones and the question I asked in your discussion.
Sure. So yeah, wound care, I mean, it is a great, there's so much available to us, and wound care evolves and changes, just like every other field of medicine. What we know today is far different than what we knew 10 or 15 or 20 years ago. So I do think, we take cues from dermatology. For example, dermatologists are doing biopsies of skin lesions every day, which are creating wounds. The number one recommended wound care product by dermatology is Vaseline, right? And so that's not a bad product either to use on wounds. But I do think my takeaway would be, if you have a wound, don't treat it yourself, right? Seek professional attention. If you're
Absolutely.
not seeing healing, if you're seeing signs of infection, you definitely need to get some good guidance. And at some point, if you're not getting the resolution, you've heard today that it should take 4 to 6 weeks to heal most wounds if we dot the I's and cross the T's. But again, my focus and what I'm really advocating is that patients take good control of their own medical conditions. Specific to prevention of foot complications, it's keep your sugars under the best control that you can, check your feet every day, and don't walk barefoot. I think if people did those 3 things, good glucose management, check your feet every day, seek attention early, and don't walk barefoot, probably 80% of foot wounds can be avoided.
And what about, really quickly, what if they want to soak their feet, go swimming, get in the pool? Any suggestions for a diabetic patient on that as well?
Is this a diabetic patient that doesn't have a wound
Doesn't have a wound.
and there's not neuropathic? Does not have neuropathy?
Neuropathy. They may not. It's good for you to address both.
Yeah, so like my parents, both of them, my mom and dad, the mom and dad who raised me, they have diabetes. If we go on vacation, I'm gonna allow them to get in the pool, go swimming, do all those things that they did because they don't have PAD, they don't have neuropathy, right? And then I'm there with them if I go on vacation with them. But if it's a person with neuropathy, we definitely recommend against they going to pedicures, places to get their toenails clipped, and doing at-home foot baths if they have neuropathy. It's highly frowned upon, and also with PAD as well. We do not recommend patients with PAD or neuropathy to do those things.
Thank you very much to both of you. Really appreciate your time, especially volunteering on a Saturday. Thank you, Dr. Jones, Dr. Rothenberg.